So this year at the EADV, we will be presenting the 12-month interim results of the AD-VISE registry. And this is a multi-country prospective study that is done in the real world, looking at how upadacitinib is performing in the real world. We already know from clinical trials that it is both the 15 milligram and the 30 milligram dose more effective than placebo. But this study now looks at how this pans out in the real world situation. So we have almost 900 patients, 856 patients who have taken upadacitinib for 12 months or greater. Of these, 55% of them were prescribed on the 15 milligram dose and 45% prescribed on the 30 milligram dose. And of the proportion that were female was about 44%. Although they came from many different countries around the world, the most common country was actually Canada at 26%, but we have other European countries as well. When patients were started on the 15 milligram dose, the most common reason for that, starting on the 15, was that it was the lowest possible effective dose for the patient. However, there was also a good proportion of patients started on the 30 milligram dose, and the most common reason for that was high disease burden. Looking over the mean upadacitinib exposure over those 12 months was 440 days. Because some people were on for greater than 12 months. And through that time, 13% of patients discontinued through that. We had time points at month 2, month 6, and month 12. And the primary endpoint was a vIGA AD score of 0 or 1, so clear, almost clear. So the results that we saw with the primary endpoint of a vIGA AD 0 or 1, which is clear, almost clear, was in the majority of patients. So as early as 2 months, 53% of patients were able to achieve that vIGA AD of 0 or 1. By 12 months, it was in 55% of patients. So the majority of patients getting that clear, almost clear skin. If you look at the EASI-90 results, that tracks those numbers are almost identical. And the other way we looked at it was the absolute target of an EASI score of 3 or less. And as we look at longer term data, especially in the real world, looking at absolute values, we feel are more meaningful because it doesn't matter where patients start from, it's where they end up in 12 months. So that target of EASI score of 3 or less was met by about 2/3 of patients at 12 months of therapy, but was already at 2 months of therapy met by 59% of patients. So approximately 2/3 over the first year, meeting that low absolute EASI score. Now, itch, also the most important symptom of this disease, what affects patients' quality of life. We found a worst pruritus NRS of 0 or 1, which means no or minimal itch, in about 1/3 of patients at 1 year. So by as early as 2 months, it was 40%, but up to the 12-month point, it was 33% of patients achieving little or no itch. One direction that we've been going, looking at the efficacy in atopic dermatitis, is minimal disease activity. And in this study, we looked at a combination of EASI of 3 or less and a worst pruritus NRS of 0 or 1. So very minimal skin involvement and very minimal to no itch. And that was also found in about 1/3 of patients as early as month 2. And by month 12, it was in 29% of patients. So basically 3 out of 10 patients achieving minimal disease activity based on an absolute EASI of 3 or less and an itch of 0 or 1. So the study is ongoing. As I mentioned, it's prospective and observational, so we will have further data points moving forward, and there will be other posters presenting on the safety. The poster we're presenting this year is focusing on the efficacy. There are many reasons why someone might choose upadacitinib for their patient in that shared decision-making when you are explaining all the options to your patient. There are as quite a number of these patients were started on the 30 milligram dose because of a high disease burden. So you may have a patient that's failed many other therapies. They're living with a high burden of disease, and knowing that 30 milligrams has been proven to give the greatest efficacy of all of the options out there, that might be one reason why upadacitinib is chosen. The rapid itch response, failures of other therapy, patient preference for an oral therapy, comorbidities that it may also help, such as things like alopecia areata, vitiligo, rheumatoid arthritis, ulcerative colitis, other diseases that the patient with atopic dermatitis may have. You might want to choose a therapy that's going to treat both of them. The other counseling tools, one thing I tell all my patients, this is a JAK inhibitor. We have it available for a number of different diseases, but one thing we do know is there is an increased risk of infections. So we would like you to have your zoster vaccination prior to starting or just after starting therapy to reduce the chances of that. I ask them if they have a history of herpes simplex infection so that they can have some antivirals at home in case they get an outbreak. And I ask them to watch out for signs and symptoms of skin infections as well. Other things we monitor, of course, you're going to want to screen for a history of thromboembolism, other histories of malignancies, just a general history to make sure that a JAK inhibitor is the best choice for your patient.